Welcome to a special edition of the NRG Oncology Podcast, focusing on the 2024 American Society of Radiation Oncology, or ASTRO Plenary Session in DC. I'm Lauren Henke, and I'm joined by my co-host, Stephen Chun. Today, we are thrilled to be discussing two randomized NRG oncology trials, HN005 and LU005, which we presented at the 2024 ASTRO Plenary Session. We welcome the principal investigators to elaborate on these landmark clinical trials. First, we welcome Dr. Kristin Higgins, the Chief Clinical Officer of City of Hope, Atlanta, and the principal investigator of NRG-LU005 for limited stage small cell lung cancer.
As background, NRG-LU005 is a phase 3 randomized trial for limited stage small cell lung cancer. For those of you unfamiliar, limited stage small cell lung cancer is an aggressive neuroendocrine cancer that by definition hasn't spread outside of the chest and can be safely treated with platinum and etoposide-based chemoradiation. This approach has been the standard of care for limited stage small cell lung cancer since the Pinion meta-analysis over 30 years ago. Given the benefit of PD-L1 directed immunotherapy seen in metastatic or extensive stage small cell lung cancer, the LU005 clinical trial has looked at traditional chemoradiation with or without concurrent atezolizumab for limited stage small cell lung cancer. Dr. Higgins, without further ado, can you fill us in on the results of LU005 just presented at the ASTRO Plenary Session?
Sure, and thank you very much to Stephen and Lauren for having me on the podcast today. So the results of this trial, I think, were at first surprising to us, certainly. We saw no benefits in terms of survival or progression-free survival when adding atezolizumab concurrently to chemotherapy and radiation. We also saw no difference in other secondary endpoints, including distant metastasis-free survival and local control. There are, I think, many potential reasons for this finding. Importantly, we know that atezolizumab is an active drug in the small cell lung cancer space. Certainly from the Empower 133 trial, atezolizumab did improve survival in the extensive stage small cell setting. I think what we're seeing here is the fact that timing of immunotherapy matters when it comes to combining it with radiation and chemotherapy. There's been, I think, a lot of other data in the background that has emerged showing us that concurrent immunotherapy is not the way to go when it comes to combining chemoradiation with these drugs. We've seen negative trials in lung cancer as well as head and neck cancer. And I think what this is showing us is that the timing of immunotherapy certainly matters when it comes to making these combinations. Certainly, I think the trial was well conducted, and importantly, we conducted it in a very rapid time period. It opened to enrollment in 2019, and we completed the U.S. portion of 506 patients in 2022. So 3 years. This is certainly much faster than the last limited stage small cell lung cancer trial that was sponsored by the NCI, which took over 10 years to complete. So I think it's important to point that out, that in the cooperative group setting, we can conduct trials in an efficient manner. Also, this was during the pandemic, which is an important point. I was really grateful to all the investigators that continued to enroll patients in this trial, despite the hardships of the pandemic that we know certainly made it more difficult to conduct clinical research. I think the other point that I want to make is there has been, I think, a myth that it's difficult to put limited stage small cell lung cancer patients on study. They have big tumors. You need to start treatment right away. You don't have time to enroll them on clinical trials. And I will say one takeaway, I think, for me is the fact that this trial did enroll very quickly. And I think it's a message that small cell lung cancer patients want better treatments and are eager to participate in clinical research. And I want to just make a point of that so that we as an oncologic community can continue to strive to develop better therapies for this patient population. Because again, if you look at these patients relative to their non-small cell lung cancer counterparts, the pace of innovation has been much slower.
That's a great answer. Honestly, that accrual pace is incredible, and huge kudos to you in guiding this trial to completion to help us answer this clinical question, but also to prove, like you said, that it really is possible to push the envelope with research in small cell lung cancer. You mentioned the importance of timing of immunotherapy, and I want to dive into that a little bit further. Recently, the ADRIATIC trial, also for limited stage small cell cancer, presented at the 2024 American Society of Clinical Oncology meeting, showed that consolidative PD-L1 immune therapy with durvalumab dramatically improved survival for these patients. Patients treated with consolidative immune therapy after chemoradiation had a stunning median overall survival of over 4.5 years. I want to point out that the important difference between LU005 and ADRIATIC is that PD-L1 immune therapy was given only after chemoradiation in ADRIATIC, whereas immune therapy was given both concurrently and after chemoradiation in LU005. Can you help us put the results of LU005 in context of ADRIATIC with respect to median survival and toxicity?
One thing to point out is that they are different patient populations. LU005 was all patients at diagnosis after they received one cycle of chemotherapy they were enrolled. And certainly this is, a different population compared with ADRIATIC, where you're sort of picking the group of patients that has already shown that they are able to complete concurrent chemoradiation successfully, have relatively quick resolution of high-grade toxicity, and not have any progression. So I think that's the first thing to point out, is that, they're fundamentally different populations. One of the other things that we did in our trial is we had a robust radiation quality assurance program. And so the first 3 plans for every enrolling institution were reviewed in real time, and feedback was given and changes were potentially made if needed before the patient started treatment. And then every other plan from that institution was then reviewed retrospectively to make sure that it met protocol specifications. In our trial, 92% of patients had acceptable or variation acceptable plans for both arms. And that's, I think, very, very high. The control arm in the study, I think, did very well. Is that perhaps because we had this robust radiation quality assurance program? It's impossible to know. But I do want to point out that when you give controlled radiation, patients will do better because radiation quality matters. So that's just like an important point. And certainly in ADRIATIC, patients were enrolled after they completed concurrent chemoradiation plus or minus PCI. So there was no way to control at all for the quality of radiation. But that being said, the results were striking. The ADRIATIC trial showed that durvalumab drastically improved survival, which was an amazing advancement for this patient population that hasn't seen any new therapies in several decades. And our trial, again, enrolling patients at the same time, has shown no survival benefit with concurrent immunotherapy, with the drugs being, I think, very similar in terms of their activity. I think it's showing us clearly that timing matters and that the concurrent immunotherapy approach is not the way to go. But, I am very thankful as a small cell lung cancer researcher that we do have a new treatment paradigm emerging with the ADRIATIC trial. Even though I'm obviously very disappointed that our trial was negative, I'm still happy that the needle is being moved and that there is better therapy now for patients with small cell lung cancer. And certainly should see an FDA approval for durvalumab, I think, hopefully by the end of the year. And so there will be an immunotherapy strategy for limited stage patients, which I think is great.
Aside from the primary outcomes that you described, are there any other things we can learn from LU005? There's the age-old question of whether daily or twice daily radiotherapy, or whether to do prophylactic cranial irradiation for limited stage small cell lung cancer is warranted. Since use of twice daily radiation and prophylactic cranial irradiation were left up to the enrolling provider, might there be anything we can learn about these controversial topics in LU005?
Yeah, I think so. So the radiation fractionation was a stratified variable in our study. Patients could receive 45 gray twice daily or 66 gray once daily. Now, of course, we know the results of the CONVERT trial, which was designed as a superiority trial looking at once daily thoracic radiation to 66 gray. That was not superior to 45 gray twice daily. However, with that fractionation trial being out there, most people interpreted that result as saying, well, you can give either because the survival is equivalent. And certainly practice patterns in the United States have shown that the vast majority of patients in the US get once daily radiation, not twice daily radiation. We looked specifically at the fractionation question in our trial, knowing that it certainly is not the primary endpoint, but interestingly, the patients that received twice daily radiation to 45 gray did have better survival compared with the once daily radiation to 66 gray. And I found that very interesting. I've always been a twice daily believer for small cell lung cancer. I believe an accelerated repopulation. And I think that the twice daily radiation is playing to that biology for small cell lung cancer to be an aggressive tumor that we need extra tools to control. So I've certainly always delivered twice daily radiation as my first offering to patients, but many people across the United States never use twice daily radiation. And so I think perhaps we need to reconsider this. I, again, interpret the CONVERT data that 45 gray BID should be the standard of care. And the fractionation data from this study, I think, kind of confirms it for me that that is the best way to deliver thoracic radiation for limited stage small cell lung cancer.
So there have been a number of trials looking at concurrent PD-L1 immune therapy with chemoradiation, not only in lung cancer, but also in other disease sites. The recent PACIFIC-2 trial, for example, did not show a benefit of adding concurrent PD-L1 immune therapy to chemoradiation for locally advanced non-small cell lung cancer. And in KEYNOTE-412 for locally advanced head and neck cancer, we also didn't see a benefit of adding pembrolizumab to chemoradiation. Could you help us put the results of LU005 more broadly in the context of these negative trials for concurrent immune therapy? What do you think the future is for concurrent immune therapy for small cell lung cancer?
I think the future for concurrent immunotherapy in small cell lung cancer is that it won't be used. The results of this trial, I think, clearly show that we should not be using immunotherapy concurrently for limited stage small cell lung cancer treatment. Now, considering the broad landscape of oncology, it's interesting because we have a series of negative trials, as you mentioned, across disease sites for concurrent immunotherapy. There is a positive trial in cervical cancer for concurrent pembrolizumab and chemoradiation. I've thought a lot about this question, and I think with lung cancer, especially small cell lung cancer, you have large centrally located tumors. And I think when we're delivering thoracic radiation, you're radiating a lot of blood volume. And we know that lymphocytes are exquisitely sensitive to radiation. And I think with that immunosuppressive effects of radiation, I think the immune system is just getting wiped out and we're not seeing that benefit that we see when immunotherapy is given sequentially. If I were designing future trials, I certainly would be very hesitant to do anything concurrently, in terms of immunotherapy with radiation in lung cancer. I think that probably the future for small cell lung cancer is building upon more combinations in the consolidative setting with PD-L1 inhibitors and other potentially active drugs in this space, ADCs, for example, and other sort of drugs that are showing efficacy, certainly in the metastatic space.
Dr. Higgins, I want to congratulate you again on this trial and thank you for joining us. One last question for you. When can we expect LU005 to be published?
So we're working on the complete statistical analysis that we will need for the full manuscript, and I hope that we will get the manuscript submitted hopefully within the next month. So it should be coming out, I think, certainly before the end of the year.
Next up, we have Dr. Sue Yam, who is the principal investigator of NRG-HN005, which was also presented at the ASTRO Plenary Session. Dr. Yam is professor and vice chair of radiation oncology at the University of California, San Francisco, and chair of the NRG Oncology Head and Neck Core Committee.
For those of you who are unfamiliar with HN005, this was a phase 2 to 3 randomized non-inferiority trial asking the perennial question of whether we can safely de-escalate treatment for favorable P16 positive HPV-associated stage 1 to 2 oropharyngeal cancer or cancer of the throat. There were 3 arms in this trial. The first arm was standard dose radiation of 70 gray with concurrent cisplatin. The second arm was de-intensified radiation to a dose of 60 gray with concurrent cisplatin. And the third arm was de-intensified radiation to a dose of 60 gray with concurrent nivolumab or PD-1 immunotherapy. Dr. Yam, congratulations on your presentation and completing this important trial. Without further ado, can you fill our listeners in on the key findings of HN005?
Thanks so much for inviting me to come and talk on your podcast. I'm excited to just fill everybody in on what happened with HN005. As many people know by now, unfortunately, the study is considered a negative study. But I think there's a lot of really interesting stuff we can talk about, and happy to do that today with you all. First of all, I just want to say any NRG trial, any RTOG trial, these are really large trials that involve a whole lot of people. And so, while I'm the person presenting it and everything, just want to emphasize that I'm really, really grateful to all the centers and all the investigators, and especially to the patients who participated in this. And I want all of them to understand that while the trial is formally negative and considered futile, what we learn from the trial is in some ways more important than the trial itself. NRG had previously done a study called RTOG-1016, and that study was attempting to de-intensify in a different way, which was trying to use cetuximab instead of cisplatin in HPV-positive patients, or what we called P16-positive patients at the time. Anyway, the point is that cetuximab did not measure up, and cisplatin was clearly the winning control arm. And that control arm became the internal NRG-RTOG standard of care. A lot of people are confused by this because the control arm in 1016 or HN005 isn't just standard 70 gray with concurrent cisplatin. It's 70 gray accelerated over 6 weeks, and it's given with Q3 weeks cisplatin for 2 cycles. And there's a long history behind that, dating back to RTOG-0522, where the group showed that 2 cycles of cisplatin with mild acceleration was safe, and you didn't have to give 3 cycles. And so RTOG-1016 has that mild acceleration, has the 2 cycles. It was the winning control arm from 1016. It became the control arm in HN005. And that's just important to understand that when we have a control arm in NRG-RTOG, we take that forward. There's many reasons for that. The most important reason is that we have such a huge mass of data around those arms that we've used over a number of different trials over the years. And so that enables us to really understand the statistical projections. And also we have quality of life data. And in this case, it was going to port over really well so that we could power the trial appropriately, but also have a lot of background data to be able to make informed decisions at the end of the trial should one of these arms, experimental arms, have become positive. So that's a long-winded answer, but it's important to understand why that control arm is what it is. And then we had 2 experimental arms. One was, as you said, the cisplatin 60 gray arm. That was an experimental arm that was taken from NRG-HN002. NRG-HN002 was a sort of old style pick the winner type of study where we had 2 experimental arms, and we were trying to see if either one was comparable to a historical control. So essentially it was really 2 parallel phase 2 arms in 002. And the 60 gray cisplatin arm in that study looked competitive. And so that was brought over as the experimental arm in this phase 2/3 with the intention to put it up against our control from 1016. And then the third arm, which was the second experimental arm, was 60 gray with nivolumab. And again, slight quirk here because this came over again from 002. In 002, the other experimental arm had been 60 gray in 5 weeks, and it sort of missed the historical cutoff, but it was close. And the thought was that if we brought that over and added nivolumab in the experimental phase 2 setting, I want to make clear, perhaps that would push it over enough so that it would actually become competitive. So unfortunately, there were 2 futility analyses that were pre-planned in advance as part of 005. Those were to be triggered at 11 events. And I want to make clear that this is a very small number of patients. We were going to accrue something like 399 patients, and we were going to trigger futility at 11 events between 2 arms. So the futility analyses were triggered if you had 11 events between arm 1 and arm 2, or arm 1 and arm 3. And so initially, the arm 1, arm 2 futility was triggered at 11 events. That was earlier on. And the analysis showed that the hazard ratio against arm 2 was over 4, clearly outside the margin of non-inferiority. And so the 60 gray with cisplatin arm triggered first and was closed. And subsequently, we actually redid the study, amended, kept going with 60 gray nivolumab, and pretty much finished the phase 2 when the second futility was triggered for arm 1 versus arm 3. And that hazard ratio was also well over 4 and triggered the second futility declaration for arm 3. So this report now is the description of the total phase 2, because the phase 2 had closed by the time of the second futility analysis. And what we discuss is how the 2 futility analyses were decided, and then the overall report of the phase 2 accrual. And so we can actually, at this point, report essentially the complete phase 2 between arms 1 and 3, and almost complete accrual to comparing arms 1 and 2. And in the end, the final result is that at 2 years PFS, the experimental arms at 89% and 90% PFS could not compete with the control arm. And this is, I think, what is maybe the major finding, which is that, sort of shockingly, the control arm from 1016 produced a sustained PFS of 98% over 2 years, and we're now heading into 3 years, and it looks like that is holding. So if I had to guess, I would say we got 98% cure from the control arm. And that is a somewhat unprecedented result, even in this population, as reported in the literature up to this point, and really indicates that with standard therapy, which I do consider 1016 control arm to be essentially standard therapy, we're talking about 98% cure. And I think that is a really important lesson that maybe we hadn't absorbed up till this point. There have been quite a large number of de-intensification trials that have been out there over the past several years. Most of them have used a projection like we used in HN002 of about somewhere between 88 to 92%. But what we now see is that actually the bar is much higher than that at 98% PFS. So it's important to understand that the experimental arms actually did decently well. They performed okay, but our standard arm performed magnificently. And I think that's a really important fact to absorb.
That's a really incredible cure rate. And it's hard to design for approaches that are going to do better than that, let alone, even creating non-inferiority in that setting is really challenging. I have to say the immunotherapy findings here seem to align with what we are seeing from several disease sites. I know that you are also highly involved with treating lung cancer. I think of trials like PACIFIC-2 and NRG-LU002, where combining radiation with checkpoint immunotherapy also didn't seem to really work. What do you think the future is of PD-1 or PD-L1 immunotherapy with radiation going forward? Is this the end of trying to combine immunotherapy with radiation for head and neck cancer?
We really didn't know a lot about this when 0005 was designed. And, everyone was trying to figure out how to combine immunotherapy with radiation, and that endeavor continues to this day. But the evidence out there at that point was really mostly preclinical. Maybe the best we had was animal models and few institutional experiences, but there was just very little knowledge. But there was a lot of excitement about anti-PD-1 therapy. And it was really looking promising in head and neck cancer because in the metastatic setting, the rates of response for anti-PD-1 therapy, still in the, teens, but, better than chemotherapy, were just really exciting for people. And the hope here, and, maybe the naive thought at the time, was that these tumors that were very responsive probably, just needed a little push. And if we could just get, a slightly better PFS on that accelerator radiation alone arm, it could be great for patients with much lower toxicity, since anti-PD-1 therapy has often been found to be more tolerable than chemotherapy in the metastatic setting again. So the thought was that the small effect might make that radiation arm as competitive. But again, we didn't account for the fact that standard chemoradiation would be so stunningly effective. And then the other thing I think we've learned since the time of the 005 design is it seems to be becoming very clear that immunotherapy is just not synergistic with radiation the way we understand chemotherapy and targeted therapy to be. One really important thing that a lot of people are starting to recognize is that fractionation and sequencing are actually really important to how immunotherapy works in combination with radiation therapy. And that's just not something that was really clearly understood. Back then, we had data that indicated that if you started the immunotherapy before the radiation, it would be helpful. If you gave the immunotherapy before the radiation, continuous with the radiation, it could be helpful. If you gave the immunotherapy after the radiation, it could be helpful. So that's why the 005 design is the way it is, because we had such like limited knowledge. We give one cycle before, we give a couple cycles during, and then there were a couple cycles at the back end for a total of 6 cycles of nivolumab in this study, because we really didn't understand that the sequencing would be so differential in how that response would occur. And now I would say, since you're asking about the future, not that I'm a full-time immunologist or understand any of this any better than anyone else, because I think the future is quite murky, but maybe one of the big questions now is that whether immunotherapy should be given neoadjuvantly or whether it should be given adjuvantly, because it's pretty clear that quite a number of trials are coming in across disease sites where giving the immunotherapy concurrently with radiation hasn't been a successful approach. But there are still very successful approaches in the surgical setting and even in the radiation setting, particularly in lung cancer, since you brought that up, the Pacific success with durvalumab being given adjuvantly, where adjuvant immunotherapy has looked pretty good. So now I think what we're trying to figure out is it neoadjuvant? Is it adjuvant? And then the other big question being, what kind of radiation? Fractionated radiation, stereotactic radiation, smaller field radiation. Those, I think, are the big questions. And so I don't think it's the end, actually, at all. I tend to have sort of a glass half full type of approach to most things. For me, I think these questions are really exciting and actually offer us a lot of opportunity to refine our knowledge better and make these things work better. And, immunotherapy is clearly not going away. It's a wonderful treatment. Radiation is a wonderful treatment. And if we can get them to work together, there could be some magic, just like we saw with Pacific and with other studies that are occurring now in various disease sites. I think there's a lot of potential still. The key thing is not to get discouraged and to keep trying. And of course, a negative trial, I know a lot of people get distressed by that and, feel like, why can we not get this to work? And why didn't we understand all this in retrospect? And the whole thing is all the things that you see in retrospect just indicates how much you have learned.
A lot of this talk about timing of immunotherapy, it really reminds me of something like Back to the Future or something. When we were in the 1990s, we were asking very much similar questions. Should we do chemotherapy before radiation? Should we do it concurrently with radiation? Should we do it after radiation? I feel like we're only beginning to understand that now, and perhaps it'll take another 10 or 20 years to understand this, but I feel like it's deja vu for our field. Now to change the subject a little bit, this might be a no-brainer for you, but I wanted to touch upon some of the terminology that can be confusing in HN005. At least I remember when I was a resident, this being, very confusing to me. And this was the terminology that it's a non-inferiority trial. And to my understanding, the primary finding of HN005 was that the 2 de-intensified strategies were not non-inferior. Not non-inferior. It's kind of a double negative that I personally have to stop and think for a second whenever I see that term. Okay, what does that mean? As many times as I've seen that, I know this is a straight concept to many of the clinical researchers out there. Clearly, certainly to the biostatisticians. But could you just help to explain to our audience in layman's terms what it means to be not non-inferior rather than just using the term inferior?
That's such a great question in some ways, because now that we do have a 98% PFS on the board, I think we are going to have to really think carefully about what we will accept in terms of inferiority going forward in this space. So one of the things to understand is that a trial tests a very specific question. And that's just something that I've slowly come to understand. It takes me a long time to understand things. And I finally do actually deeply understand that now, that a trial tests a specific question in a specific population in a certain time. The specific question is, were these 2 experimental arms inferior? Will they cross the boundary that we set that declares them to be inferior to the control? And that is what this is testing. So this is testing, hopefully, with the alternate of that hypothesis being that they are not inferior. And that's what non-inferiority is. It's not inferior, meaning they fall within this range, this boundary that we set that defines where something becomes inferior. Not non-inferior means that they did not satisfy that boundary of non-inferiority. But I do think you can actually say, frankly, in layman's terms, they are inferior. Now, this is different than testing, for instance, a question of superior versus inferior. And I think when you talk about superior versus inferior, that's different than non-inferior versus inferior. When you're testing for superiority, you're looking for whether an arm is actually better than another arm. And so I think the problem is that inferiority sort of fits in both of those worlds in kind of an imprecise way. It doesn't actually tell you what was being tested for. What were you testing for? You were testing for superiority of this arm to another arm, or you were testing for non-inferiority of this arm to another arm. So it's just, I think, a term of precision. But frankly, you're right. At the end of the day, these two arms are inferior to the standard of care, and that's clearly what happened. But I think the bigger question I would bring up here is, number one, how do we go forward in this landscape now where non-inferiority will be defined by such a high level of success of an experimental arm? That's really hard. That means that the number of patients that will be needed to establish that is going to be quite large. You saw from our earlier discussion that futility here was decided on the basis of 11 patients, and that was with an inferiority boundary that was extending down to an acceptability of 90 or 90.5% or something like that from HN002. Now we're talking about 98%. And then you have to make a decision, how much are you going to discount that and still consider it non-inferior? To some extent, that's a feasibility question because you just may not be able to marshal enough patients to make that inferior boundary super high. At some point, probably you have to make some decision. What can we marshal an adequate number of patients to test in a reasonable amount of time so that the trial is still relevant and accrues at a decent rate so that it's statistically valid to be able to prove this non-inferiority of this arm? It also goes to a little bit of an ethical question, which is when you're talking to your patient in the room and you tell them that something is non-inferior, do they actually perceive that the same way you do? So let's say that you've set 5% as being non-inferior. Does the patient understand that non-inferiority in this context means that their cure rate could be 5% less, right? And so that's a very complicated area of research development. There have been, for instance, non-inferiority studies where they have convened patient panels to talk about what they would accept as non-inferiority. There have been different kinds of experiments they've done with trade-offs where patients have decided what level of percentages that they would accept in exchange for some toxicity or some additional treatment. Different things like that are ways that you can get to understanding that, the NRG has typically gone off of consensus basis, meaning that the committee, the core committee or the general head and neck committee comes to a group consensus as a community about what they will do as far as non-inferiority and what they will accept and accrue to. But there's a lot of different ways to go at that. And now that the cure rates have become very high, I do think this is an issue. We have really, in the head and neck committee, put patient advocacy much more at the forefront. We now have 3 advocates on our committee as opposed to 1. They sit in on all our calls. They are reviewing all our protocols. Going forward, non-inferiority will have to be more of a decision-making process that does involve patients. That's my personal belief. But there are still feasibility questions as well. Long answer to just say that this whole term of non-inferiority will become a very, very important research area and discussion area for our group going forward.
No, I really appreciate that explanation. That's the kind of explanation I really wish when I was a resident, someone would have sat down with me and just very clearly explained. Another topic I wanted to talk about, I think Kianang was someone who you probably knew well. I never met him, actually. Now you fill his shoes as chair of the Head and Neck Core Committee. I think he'd probably be very proud, of where you are right now. And it's hard to believe it's been almost 20 years now that Canang got us thinking about de-escalation for P16 positive oropharynx cancers in trials like RTOG-0129, where in that classic New England Journal of Medicine publication showing these cancers had such favorable prognosis, certainly not the 98% we're seeing in HN005, but rates, approaching 90% in these tumors compared to the P16 negative tumors, which were far less favorable. That started us thinking about how to de-escalate. But what has made it so hard to de-escalate these past 20 years? I feel like it's something we've been talking about since I was a medical student.
We've been talking about it a long time. One thing to understand is that those historical studies had a much more mixed population. And what has happened in head and neck cancer, as has happened in many different kinds of cancers, is we have these very small subsets. And so one thing that we haven't talked about yet, which I should point out, is that HN002 and HN005 were the 50% of 1016 that performed the best. So this is the non-smokers, local, regionally advanced, but limited disease extent. And those patients just have an incredible prognosis. You could argue that maybe it wasn't the most strategic decision in retrospect to try to de-escalate in this population where the cure rates were going to be so high that it was going to become so difficult to do these huge trials. But it also was a decision by the committee long ago that we didn't want to try to de-escalate where patients were still not doing great. So there's been kind of a bifurcation, which is like, we'll take the patients who are doing great and try to see if we can maintain that, hence de-escalation, non-inferiority. And then we'll take the patients who aren't doing so great and we try to bring them up in whatever way that means. Smarter therapies, maybe more rigorous therapies, maybe layering on more therapies, hopefully not too toxic, but trying to find ways to bring them up again while controlling toxicity. And what's made it hard to de-escalate is because we have, a small subset of patients now within the HPV positive population. They have extremely terrific prognosis. And I also think that it just takes a lot of time to learn things and run these trials. Again, I have a very optimistic view. I actually think that we've gotten really far. You have to remember that HPV was identified as a potential etiology for these oropharynx cancers only in 2000. Well, that's when PCR technology became available and they started to be able to make the scientific link to HPV virus. And since then, we've done so much. We found out that P16 was a good biomarker. We established all these prognostic categories. You mentioned RTOG-0129 with the very, very well-known now recursive partitioning analysis. We changed the staging system to make P16 positive oropharynx cancer a different disease entirely with its own chapter in the staging manual. We developed new surgery paradigms, right? Because that was the development of TORS. And now we're developing more consensus definitions around imaging and pathology definitions that are much more precise. So, and you could also throw in there, we've learned so much about HPV with the benefit of sequencing technology and understanding the different kinds of HPV types and their association with different kinds of mutations and whether they're in episomal form. And, all of this is knowledge that just, has grown out of this couple of decades that we've been working on this. The other thing I would just say, and the reason I feel very optimistic, is that because we understand the disease, because the community recognizes that these patients will potentially have a great prognosis and live a long time, and that we have to be really careful about the late toxicity, since the community being so conscious of that, we have changed how we treat patients. And that goes a lot to the really intelligent ways that radiation therapy is delivered now. The IMRT techniques are super sophisticated. The margins, concerning when we started in 0022, the first IMRT feasibility study, where, the margins were 1 centimeter, and that's unheard of now. Now we're down to, millimeters. Point being that we're decreasing the margins. We have much more careful delineation with, all these courses you can take and, all the standardization of contouring and now auto contouring. It's just a much more refined way that we're delivering the radiation. I'll also mention out there that fields in general are getting smaller, and I don't know that we're quite so standardized yet. We're probably going to work on this within NRG. We've done a lot with our protocols where we describe how to design your treatment volumes, starting with 002, which was the first study ever to actually describe the conditions, criteria, and treatment paradigms for unilateral therapy. So we're working on all of that, but we probably do need to standardize that more, which is how we actually design the treatment volumes. All over, people are, using much more careful, much more restrictive treatment volumes on these patients. And so I feel like they're doing that because we are conscious of HPV and the incredible survival. And that's been just a natural development because radiation oncology is always internally improving itself. No matter what the trials are saying, I have such great faith in our field because it's just always getting better. And that's something I think a lot of people don't actually understand, patients perhaps, included, because they hear about radiation from 20 years ago and what patients and maybe some of our colleagues who don't have the benefit of seeing our field up close all the time don't know is that there's just a natural development of technology that makes the radiation better and better all the time. And so I am not optimistic, to use your double negative. I actually think we are de-escalating treatment. And we're not just de-escalating treatment for HPV positive patients on trial, we're de-escalating treatment for everyone. The toxicities now are so much more manageable, still tough to get through head and neck treatment, but so much more manageable than when I started my residency, for example.
I really like your optimism. I like to call myself a pragmatic optimist, and I see or hear a lot of that in what you're describing. And I really do think it's true that these trials that we conduct, even when the endpoint doesn't return a positive or create a new standard of care, it still teaches us so much. And, I think we've truly learned a lot about how to use immunotherapy with radiation or how not to combine the two. That said, I want to confirm that in 2024, concurrent chemoradiation to 70 gray with cisplatin remains standard for a P16 positive stage 1 to 2 oropharynx cancer. And with the idea of this expanded learning that happens with these trials and the experience, is there anything we might learn from perhaps future ancillary analyses of HN005 where we might be able to add to that de-escalation picture?
Yeah, thanks so much for asking that because, again, maybe I just have to be optimistic because what else are you going to do? But the fact is I am actually pretty optimistic. If you look at the trial results, 60 gray works in a lot of patients, right? I mean, it works in the considerable majority of patients. It just doesn't work quite well enough. And so that tells me that de-escalation isn't out of the question. We just have to figure out how we can select those patients so that everyone's getting what they need. So for that majority of patients that really does have the ability to take less treatment. And when I say less treatment, I mean all kinds of treatment. I think of this broadly, the radiation, the chemotherapy, whatever they're getting, surgery as well. Like if they can have less treatment, less modalities, we should find those patients. We should do that for them. And then we need to be able to figure out mechanisms so that we can identify those patients who really do need to stick to that standard of care. And that's how we're going to progress and move de-escalation forward. It's clearly not going to be this large group of patients that we selected for HN002 and HN005. But for a majority subset within that population, we can do this. So I remain pretty positive about that. And, within NRG Oncology, we have all kinds of things we're working on. I talked a little bit about how we're systematizing and studying radiation volumes. We're also working in HN009, which is an ongoing trial right now, looking at whether we need that every 3-week cisplatin dose or whether we can change to weekly cisplatin safely, and what the toxicity benefits or changes would or would not be. I think that's actually really important data that's obtained within the United States with the standards of care we have in the United States, and to understand that question. So, we're looking at a lot of different components across these trials. Certainly, there are many very exciting biological and imaging biomarkers that are being proposed, and we most likely will be looking at some of those as well. And I really do think that probably what all of these biomarkers, they have kind of varying discrimination ability and sensitivity and what have you, but probably what all of these biomarkers share is that they are trying to distinguish a population within this population where we can de-escalate. And that to me is sort of the future of cancer care and cancer trials, which is giving patients what they need. Anyway, that's how I kind of think about this. And so I feel like that's the big learning lesson from HN005. And I'll just say, I don't see the future as closed at all. I actually feel like this was a successful trial that did what it was supposed to do. It found that these two arms are not appropriately non-inferior in this population. And so we take that and we dissect that statement and we figure out what we do to keep going. I'm very happy that for the great majority of patients in this trial, they got benefits from de-escalation.
Well, Dr. Yam, thank you again for joining us and for all the work that you do with the NRG Oncology Head and Neck Core Committee. Congratulations again on your plenary presentation at ASTRO 2024. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily represent that of the National Institutes of Health. Thanks for listening to this special NRG Oncology podcast on the 2024 American Society of Radiation Oncology Plenary Session, and happy clinical trials.